So let's look at digital workflows. Basically, my assessment of this is that it's any process which involves, from a clinical point of view, in the practice what we're doing is we're taking intraoral scans, or we're taking cone beam CT scans, and the file format from those two systems, from an intraoral scan system, is an STL file, and as you probably know from a cone beam CT scan, is a DICOM file, or DICOM files can be up to hundreds of those, 343 for a single arch scan from my Carestream scanner. Moving on from that, so those are the files. Then we move those files into our software for design, and ultimately then once designed for production. And some of this design is done by AI these days, some of the crown design, rather than being worked up from a manual process, if you like, on screen. So we're seeing with these digital workflows is a move away from conventional workflows, from analog, from impressions, from casting alloys and bars out of gold alloys and semi-precious alloys. All of this is moving in a ground change over the past number of years, and moving very rapidly away from all those traditional techniques that we knew that relied on manual production. Now we're into this CAD/CAM production where we're seeing a lot of milling done either of ceramics or metals such as titanium. So if we look at this slide, we can see the intraoral scanner on the left. The other option that is done, and I have used it before, is take a physical impression, sometimes in halogen, sometimes in a silicone, and then use either a lab scanner or an intraoral scanner to scan those impressions. Those files, which will be STL files from the intraoral scanner, are then going into our computer system, into our software, where the restorations are designed, and then they're on to production, which is either milling, or which is commonplace these days is 3D printing. So let's look at some of the advantages of digital workflows. One clearly is turnaround time, where if you take a scan in your practice, that scan, once finished and sent, can be in the laboratory within seconds. Accuracy, I have a question mark beside that. Certainly full arches scanned with intraoral scanners, there's a question mark over that, over the accuracy of those, and I'll deal with this later on and ways around this later in the presentation. Improved patient experience, certainly patients will prefer your intraoral scanner to impressions. That can be particularly marked in patients who have a severe gag reflex. They find obviously digital intraoral scans much easier than impressions. Another thing that is useful is that I find is prep analysis, where if you have a margin that you know where it is clinically, but it's difficult to see either on an impression or on an intraoral scan, you can mark that margin because you as a clinician know where that margin is, and then you can transfer that off to the laboratory to trim the dye to that, or mark the dye to that margin that you have scribed on screen. Undercut analysis again is a useful function to eliminate undercuts, and the other one is occlusal clearance, where you can, I think I'll show this in some of the later slides, where you can determine or measure even the amount of clearance that you have prepared from an interocclusal space provision. If that's too small, your restoration is going to be compromised. And one of the other advantages is magnification, in that you can magnify the size of your prep on screen, and you can modify that accordingly and rescan. Another useful thing is record storage. Obviously models and impressions can't readily be stored. The models obviously take up a lot of physical space, whereas the digital files can be readily stored on the cloud. I've mentioned improves patient and lab communication. You can send, for example, ExoCAD designs, which I'll come to later on in the presentation. You can email those off to your patients for approval or for consideration. And lab communication, I've mentioned that earlier, with things like margin marking, determining where that margin is, and also some of the online order processes that can be done through various laboratories and can facilitate and enhance that laboratory communication. You can upload files, you can upload photographs, you can upload CT scans onto some of these platforms, which enhances that dentist to lab communication. Because we're using obviously less packaging and there's less transport of physical impressions and models, it's more environmentally friendly to use digital workflows, leaving this whole aspect of care more sustainable. And you've got, as I've mentioned, you have savings on materials, your impression materials, your impression trays, you've got adhesives, you've got silicone material, you've got opposing arches and alginate trays, you've courier costs and you've postage costs. These are all eliminated largely with the digital workflows. Some of the disadvantages are cost. That's the initial capital cost of the, for example, it could be the CT scanner, or in our case more particularly is the intraoral scanner, which are relatively expensive, although costs are coming down with these. And if you weigh that up against the cost of materials, trays, adhesive, remakes and retakes, the costs probably are not huge there. Over time, the intraoral scanners will probably save money. There is a learning curve. Intraoral scanning does take a bit of practice to get proficient in it. I reckon it takes between 6 and 8 weeks of regular scanning in a practice to get proficient with your scanner. Also, some IT literacy. You need to be fairly proficient on the computer to manage these workflows adequately. And again, accuracies, particularly full arch implant scans, may not be as accurate as a silicone impression. So let's look at some of the workflows. As I've mentioned earlier on, we have intraoral scanning. We have got facial scanning, which allows for facially driven aesthetics and restoration planning. Digital shade taking, implant planning. I'll mention a bit about TRI implants, which is a system that I use, which is termed a digital implant system, but I'll come to that later. Some implant retained prostheses we'll discuss. Digital dentures, or digitally produced dentures, as I like to refer them to, and the composite injection technique, which allows us to manage some aesthetic and wear cases. So if we look at some of the features of an intraoral scanner, I'm sure everyone now knows that these things have both come down in price and also come down in size. I had a look at one of the old original iTero machines in the laboratory today, and it's a massive thing made of probably of cast iron, very heavy, and a very cumbersome handpiece. So we've now got down to a very sleek designed handpiece. It warms the tips are interchangeable, it can be autoclaved. There's a motion sensors on some of them. This electroscanner allows you to move. If you move the scanner, your image on the screen will move as well. Moving on from that, various applications that can be used for all aspects of treatment these days. Anywhere where you're taking a physical impression, you can use your intraoral scanner. That includes implants, crown and bridge type restorations, orthodontics, etc. I'd mentioned some of the features earlier. Some of those that I mentioned earlier were undercut analysis, margin marking. You can also take a pre-operative scan and use that. The contour of that you may want to reproduce that, so again the technician can use that. You can monitor various aspects of treatment. That could be the monitoring of orthodontic treatment, or it could be the long-term monitoring of wear cases, where you want to compare a case that you're reviewing today compared with let's say a year ago or 2 years ago. You can superimpose scans and see changes or look for changes on those scans over time. Occlusal clearance I've mentioned as well, and that's something which is useful during preparation. Let's look at the RAYFace, which is a face scanner. It's a Korean device that's used. I use it occasionally for planning anterior restorations. Those can be orthodontic restorations, or you can import exocad images, modify those, and see how those fit with the facial profile, with the face, what we call facially driven treatment planning or facially driven aesthetics. So that's the setup. You can see on the screen that you can modify tooth length, width, etc. You can move teeth around, you can align things. You can then copy these images and transfer those through then to the final restoration. You can integrate it with cone beam CT scans. You can see in this case that the inferior dental nerve on the right is traced on, now on the left. You can see the maxillary sinuses. You can see also the teeth that are mapped on the image as well here. And this could be useful for implant planning. So that's RAYFace. Moving on to articulation, and this is an area which has gone through a transition at the minute. We're moving away from face bows and semi-adjustable conventional articulators on to articulation that is done in the virtual realm. 3Shape have what's called a dynamic occlusion, which will record. It's almost like a recording of the jaw movements, both lateral, right and left lateral, and also into protrusion. Those dynamic functions then can be transferred through to the restorations. The various articulators can be used, and also this trend towards model-less production, where the crowns and up to 3-unit bridges can be milled and finished model-less. And again, obviously that requires, if there's no model in place, that needs to be, the occlusion needs to be considered virtually. So this video shows, or should show, some jaw movements that can be facilitated with the virtual articulator. There are also things like ModJaw and various other programs that can be used. These aren't in common use at the moment, and it's certainly something which is going to go through this transition as we move away from the conventional articulation through on to the virtual articulation. This is a wax up, showing a wax up of, it's a case actually that I'm due to do this Friday, where the patient in his late 50s who's got considerable, well, relatively marked wear on his upper anterior teeth. He's got staining. There's a diastema, quite a large diastema between the ones, as you can see, between the central incisors, which he wants reduced somewhat. You can see the wear across the incisal edges. So we've waxed that up. You can see on this now that we've got the superimposition of the wax ups versus the underlying teeth. So we're going to add some labial bulk and also a millimetre and a half of incisal length to improve the aesthetics for this particular patient who's keen to do so. And I'll discuss how we're going to do that later in the presentation. Just quickly through, I'm not going to delve too deeply into smile design, but again, that can be done digitally. We can make all sorts of measurements, gingival contour, gingival zenith heights, tooth length, tooth width, angulation. We can assess on the left hand side, and we can wax up on the right hand side, and you can make measurements and various determinants of changes that you wish to make, and those can be emailed to the patient for assessment, and this obviously helps then with the consent process as well. Moving on from that is just quickly one quick slide on digital shade taking. I use in my practice, and I have done for years, is a system called RAYPlicker, an unusual name. It's a French system from a company called Berea. I find it very useful, especially just in the initial part of shade taking, where it gives me a sort of a ballpark figure as to where I should work around, and then I I very often then go on to just basically eyeballing the shade from the Vita 3D Master Shade Guide. Various other ones that I have tried with less success are the Cobra from Berea and the Opti shade from Style Italiano. But Ray Plicker is my go-to in my practice. It's a simple machine to use and it works well for me. Implant planning and guided surgery. I use implants regularly in my practice. As I mentioned earlier, it's my practice limited largely to implant and prosthodontics. Almost 99% of my cases are guided, and I'll just talk you quickly through how I plan my cases. So I'll take a combination of a full arch scan. For example, in this case, it's a maxillary scan. It's the replacement of 2 premolars, upper left 4 and 5. Replacing those teeth, I want to place 2 implants. So I'll take a maxillary CT scan, and I'll take either a silicone impression and scan that or transfer that to the laboratory, or an intraoral scan. The technician then sends me back a plan that I will then review and modify. And as you can see here, the top part of the slide shows the specifications of the implant. In this case, it's a TRI implant, it's a TRI matrix implant, which I'll show you an example of later on. It's a bone level matrix implant. It's 3.7 mil diameter. Sorry, 3.7 mil diameter of the implant. It's an 8 millimeter long, and the platform size is 3.7 as well. So you can see there the planning for that. It's close to the maxillary sinus, hence the short 8 millimeter implant. The implant shown at the bottom left of your slide shows relative densities. Probably not an exact science here, and you can see on the key on the bottom right, it goes through from bone density D1, which is the grey, down to D4, which is yellow, and in this case we're seeing mostly greens, which is D3. So it gives us an indication of bone density there, and that helps then me decide just what my drilling protocol will be. For example, if there's a lot of black or yellow, then I will tend to undersize my osteotomy slightly so that I'm getting a better primary stability when I place the implant. Moving on from that, various other images that you can see of that particular implant planning with the implants in the 4 site and the 5 site. And then from that, you can see the image at the bottom showing the surgical guide, which has 2 channels which will be fitted with 2.3 millimeter diameter metal sleeves for the TRI pilot drills. So I'll simply make it a crestal incision, retract my flaps, place the guide, and then simply drill to depth on the 2.3 pilot drills. At that stage I discard the guide and just then work up freehand up to the final dimensions that we've planned. So let's look, we mentioned TRI implants earlier, let's look at those. The one in particular, TRI do a performance line, which is, it has a similar connection to the old Zimmer TSV. However, the more modern one is the TRI matrix implant. In this case, you can see on the slide, we've got a tissue level type implant with a 1.8 millimeter high pink anodized collar. Some of you will be familiar with the Straumann tissue level implant, which flares out to I think it's a 4.7 mil diameter or 4.7 mil platform. In the matrix it's either 4.5 or 3.7, and the advantage of this system is that you have access to that that tissue level implant, sometimes called a multi-level, because it can actually be sunk, the pink collar can actually be sunk slightly subcrestal. But the other advantage is that you've got a monolithic zirconia crown or bridge. It can be a full arch bridge that is screw retained onto the implant platform. So there's no metal, there's no abutment with this, so there's no cement. It simply is monolithic zirconia. It can be layered, but most of them are monolithic, especially the posterior areas or areas that would be subject to chipping. You would prefer a monolithic restoration, and that's simply screwed into the top of the implant, as you can see. So there's no abutment. Matrix on the left, just single all ceramic crown versus a conventional restoration which may have a titanium base with a ceramic crown overlaid. So you can see you've got a lot less components of the matrix on the left with a 3-unit bridge, simply screw retained through onto, one is tissue level, the other is bone level, and on the conventional implant on the right you can see using an angled multi-unit abutment and a straight multi-unit abutment with titanium bases on an all ceramic crown. It's quite a complex structure, adds to expense, adds to complications, and simply not as reliable as the matrix. The various materials, you can use metals if you like, milled titanium or chrome cobalt alloy. You can use zirconia, or you can use PMMA acrylic for temporaries. It can be used for single crowns, multiple units, bridges and full arches, and we can also use we're all familiar with angled screw channels now, which corrects to 20 degrees. Let's look at a particular case that is a let's call it a digital case to fit with this evening's presentation. University of Zurich. This is a case that was done in Zurich. 3 o'clock Central European time. The implant was placed. Scanning the implant at 3:30. 4:15 the restoration is 3D printed and polished and finished and ready to go. 4:30 the implant's in and the temporary crown in PMMA has been screw retained, and it just leaves the access to be sealed. Let's look at another TRI case. This is one from Joel Teles, from Portugal, who presented this in Grindelwald at a course that I was at last year. Missing central incisor. The other central incisor is a failed post crown. Those are the implants in place with temporary crowns on. So again, we're using these strictly speaking tissue level implants, but in this case we're referring to these as multi-level because you can, as I mentioned earlier, you can sink those below the crest slightly. This case there was no grafting. If I show you the previous slide, you can see that there's a considerable buccal defect there in the upper left central incisor site. No grafting, soft tissue grafting was carried out, a modification of the soft tissues with temporary crowns to achieve that result, which is quite a remarkable result on all ceramic crowns, again screw retained. You can see there the image at the bottom in the center of the screws fitted through the all ceramic crowns with no metal bases, no abutments, no cements, and a very biocompatible restoration, which is also hugely aesthetic as well. This is obviously layered zirconia, but very aesthetic, and the final outcome. And again, just referring to the TRI matrix full arch cases, you can see a case here which is like an all-on-4 case. You can see the angulation of the implant in the lower right premolar area, which is huge angulation, as is normal in these all-on-4 cases. And that can be corrected, that can be facilitated readily within the restoration. Let's look at a few other implant retained restorations. These are all, you can see that these are all planned on the computer. They're all CAD/CAM designed. New designs that we're doing is a milled bar that has a zirconia tooth section. So the dentition is made either in PMMA or zirconia. That's not removable that zirconia framework is then bonded onto the metal bar to provide that restoration, which is very strong and also very aesthetic. So it's just screw retained full arch bridge work, which is zirconia again with pink ceramic. This one is removable. We've got a bar again on matrix implants with clips. You can see they're hater type clips and the hater type connections there on the bar with the three, those wee they're usually Bredent plastic clips that are placed in these. Allows for repair of the prosthesis and also facilitates good oral hygiene beneath the bar, the fact that the tooth component can be removed. And the patient obviously can have a spare one of these as well. They can take one on holiday if they lose, fracture or whatever of the tooth component. I mentioned earlier on the inaccuracy that's associated with full arch implant cases. This is due to the fact that you've got, let's say, an all-on-4 case where you've got 4 implants scattered around an upper or lower jaw, and you've got very smooth mucosa between the implants. And the scanner then it can pick up the scan bodies on the implants, but it's that the mucosal tissue between the implants that it has difficulty to stitch those images together. So there are various things that we can do. You can see on the bottom left we've got a thing called Scan Bridge, which is a design from, again, our Swiss colleagues TRI, who you place your scan bodies, which are actually the impression copings, but double up a scan bodies onto your implants, and you've got these plastic connectors that bond on or that are pushed onto the scan bodies that connect between scan bodies, so that it makes the stitching easier. You can use floss with Duralay on it, whatever, again to facilitate this stitching. Various other aspects that are done. And there's various techniques that will allow you to do both, to scan and to record a digital bite registration. In this case we've got one of the more expensive and more precise means of digitally recording implant positions, and this is using an extraoral scan. This is the iMetric system, which uses things you can probably see at the bottom left of your screen. You've got things like dominoes that are placed on multi-unit abutments that are placed on the implants, and then an extraoral scan taken of those. This certainly is, as I mentioned, is very accurate and more accurate than intraoral scanning. So I mentioned the extraoral scan with the dominoes and the issues then with scanning and stitching and inaccuracy of full arches with intraoral scans. Intraoral scans are fine for smaller, certainly for single units, 3-unit bridges, whatever, but once you get onto full arches then the accuracy does reduce down. And you can see here a case where we've got 6 implants. Issues with the fit of the bar due to inaccuracies, and you can see circled on those 2 implants there where the bar doesn't fit particularly well, so therefore it can't be used. It's not a proper fit. This system by Philip Nuitens from, I think, from the Netherlands, uses a system that we call CAPS. Where again we have scan bodies that go onto multi-units, and then we've got these cylinders so the cylinders going onto the multi-units, and then you've got these plastic or PTFE cylinders then that screw into these vertical cylinders. And you can see in the image on the right the cylinders in place, and then we've connected up through the screw channels a series of these peak cylinders that almost connect and allows the scan to be more accurate. Different lengths of these, and you can also then, on top of the gold anodized vertical cylinders, you can then place a platform that is not shown in that slide. You can see it on the slide on the top right. Those wee flat screws, or screws with flat heads on them, will screw into the cylinders, and then you can use that to record the jaw registration as shown on the images on the left, and showing the intraoral scans then on the right side. So this is allowing you to record implant positions and also the jaw registration. And then following on from that, the technician can then mill a verification jig in PMMA, which you can use your Sheffield single screw test to check for a passive fit of the verification jig to determine the accuracy of the actual working model itself. So again, that's your PMMA jig in place on the top left, various images taken, radiographic images taken to determine the accuracy of fit. Moving on to digital denture production. This is something which is starting to come into play now in clinical practice, and I have had quite good success with this over the past probably 18 months or so. If we start with the image on the top left, it's a patient who presents with, just for example here, a patient who presents with dentures that the teeth are still in a reasonable condition, the occlusion is reasonably satisfactory. Tooth length is good, occlusion's good, but the fit is not good. What you do in this scenario is to take a reline impression inside the denture bases, and then you will take a bite registration and you'll do an intraoral scan. It's a 360-degree intraoral scan of each denture, and then another scan of the dentures with the jaw reg. The technicians will then plan on on computer CAD CAM. They'll produce or work up the tooth position to provide the option of a monoblock try-in, which is basically just one colour. The tooth colour is around about an A2 shade. It's acceptable from a tooth coloured point of view, but the flanges are generally in that colour as well. And what we've started to do recently is to colour, or simply to paint, the flanges a pink colour. Those are just used for a try-in. They're used to assess occlusion, tooth position. The other advantage is, because obviously they're not made in wax, the patient can take those home and try them, show them to their family. They can even eat with them in and assess them carefully. You can review them, and then you don't need them back again. You can then just basically print the dentures or mill the dentures from the original file that you have. If you have to modify them, you can trim them. It's not like wax where you take teeth off and soften wax up. Obviously with this you have to do a bit of grinding or trimming, or other forms of correction if necessary. The iVoClar system is quite a complex system. It needs quite a bit of kit to allow you to use this system to its full advantage, and also requires a bit more training in the use of this technique. It is a good system, but it's slightly more advanced than normal denture prosthetics for the average dental practitioner. Again, this just indicates the CAD CAM side of things, or the CAD side of things, the design side, where the teeth are set up virtually on the computer system, and then in our case we tend to favour milling of the final restorations of the final dentures. However, for the try-in, for try-ins we will 3D print, as you can see here, simply just one colour. But now, as I mentioned earlier, we're painting the flanges pink so that it looks more gum-like in a sense. We're using PM7 mills to mill the final restorations, the final dentures, and we're now milling up to 10,000 of these dentures annually in our production facility in Emmerich in Germany. So the process that we favour, as I mentioned, is milling rather than 3D printing. We find that it's more reliable, and the long-term results of this are more predictable, At the moment, some laboratories are printing their dentures, but as I say, we prefer the milled restorations. In this case, interestingly, the denture is milled from a block that contains both tooth coloured and the pink base in one puck or one block. It can be done. What we do is mill from 2 blocks. One is obviously the pink base, and the other then is the tooth coloured teeth section. These are milled slightly oversized initially. The teeth are then bonded into the denture base material, and then they're back into the mill for the final milling down to proper size. Removes all the excess bonding resin, and then they're finally polished and fitted to the patient. One of the advantages, the main advantage, is that you're getting a better fit, because you're eliminating any thermal or processing inaccuracies. And the other advantage is that once you've made a set of dentures, you've got those dentures on file, so that if a patient loses them, you can easily reproduce them again. It's simply just push a button and you get another set of dentures, which is useful. Or you can mill 2 sets of dentures, one as a spare for the patient on delivery of the new dentures. Moving on to tooth surface loss, and again, this is an area where I've had good success in my own practice with this particular technique, using a composite injection technique, particularly for tooth surface loss, for tooth wear cases, but it also can be used to enhance and improve aesthetics, for example after orthodontics, or for, as we saw earlier on, I think we showed you the ExoCAD design, where I was it's the case that I'm doing later this week, where I'm increasing the length and improving the overall aesthetics of an upper anterior case. The material I use for this technique to build up as part of the composite injection technique is Genial Universal Injectable from GC. And the advantage of this material is that its flexural strength and other physical characteristics are actually better than a paste composite. 2 examples are shown here: Filtek Supreme XTE and Tetric Evo Ceram. Those are both paste composites, but the Genial Universal Injectable has better physical characteristics than those 2 paste composites. Some of that is due to, and also the long-lasting polish and the lack of reduced wear, and the resistance to staining comes from the homogeneous nature of this material, as shown in the section on the right, where you've got a very homogeneous structure, compared with, for example, the microhybrid on the left, where you can see large chunks of the quartz, the filler particles embedded in a resin matrix. These chunks of the quartz particles will be removed as the teeth wear with time, and that will allow for greater staining and a greater rate of wear as well. So we can see on the slide here that we've got reduced 3-body wear on the Genial Universal Injectable, less discoloration, better gloss retention, and better resilience or toughness compared with the paste composites underneath. So let's look at the case that I showed previously there. We've got fairly classical erosion pattern on the palatal aspects of the upper incisors, and some limited tooth surface loss on the upper canines. We do an assessment. We then do an ExoCAD wax up to determine how the final result is going to look. You can then, from this, you can print models with that particular morphology, and you can provide a putty key, where you inject into the putty key, place that in the mouth, let the material set, remove the putty, and trim back the excess from the temporary crown material on the teeth, and that will allow you and the patient then to assess the final outcome. That is then removed, obviously, and then you can go on to production of the final clear silicone injection molds for the composite injection technique. And for this, I prefer the alternate tooth wax up technique. For example, you'll see on the upper model, the number 1 labels model, where the upper left 2 and the upper right 1 are waxed up to the full dimension, and it leaves the upper left 1 and upper right 2 still at that worn initial presentation state. And then number 2, the model beneath, is the full wax up. So you can see here, what we do is use the number 1 first of all. That's the alternate teeth that are waxed up, and then secondly then use the second mold with the full wax up. So let's go through the clinical case just quickly on this to show you what we have. That's the pre-op condition. Then we isolate off the alternate teeth, those teeth that we're not restoring, isolate those off with PTFE. Etch and bond the teeth that we are restoring, fit in the clear silicone matrix, create an injection channel through. You basically inject through that mold on the teeth that you're restoring. You remove that, you remove the PTFE from the teeth that haven't been restored, and then you go back and etch, bond, and then you use the full wax up mold to complete the case. So you can see the completed case, which is certainly a better aesthetic outcome than the patient presented with initially. And also with the composite resin in place, it protects the weakened or the exposed dentine on the palatal surface of those upper incisors, and therefore prevents further wear with time of those. And these restorations are quite durable. I've reviewed my cases now a year, 18 months later, 2 years later, and the aesthetics are still very good. Sometimes they'll chip, especially in wear cases where you're building up teeth significantly, and if you're allowing the dentition to dial in and before you've provided posterior support, you find that you may get some chipping of those anterior composites, but those can be very easily repaired. And if you compare that with ceramic restorations, if you chip a ceramic restoration, it is impossible almost to repair that, and sometimes you have to replace it. So the technique is useful, good aesthetic outcome, protects the exposed dentine, prevents further wear, and is easily repaired if necessary. And that basically concludes my presentation on digital workflow this evening. Hopefully that's useful. It's a pretty light touch through all of those particular areas of interest. Those are areas, almost all of those I use in my clinical practice not a daily basis. I work part-time now, but when I do work, I use those. Almost all of those. I use TRI implants, I use this composite injection technique, I use the implant planning, facial planning using the RAYFace scanner. So if anyone has any questions, you can either pop them into the chat box now, or I'll provide my contact details, and you can either WhatsApp me on the number that's provided on the screen, or you can email me to my email address, which is provided. Thanks very much for your attention this evening, and good night.